Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen, and I thank you so much for listening today. Go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great little study guide, great refresher if you're out in practice. No-brainer, simply an email will get you access to that. Also, by subscribing, we get you access to any new content that we have available as well. So go do that, reallifepharmacology.com. All right, let's get into the drug of the day today, and that is meperidine. Now, this is definitely an older medication. Brand name of this medication is Demerol. It has been around for a long time. When I first started practice in 2009, I saw this medication a little bit. On a positive note, I can't recall really the last time I've seen meperidine used. It's been quite some time, so that is a good thing because we've definitely got some warnings and potential adverse effects associated with this medication. So first and foremost, meperidine is an opioid used in pain management, or can potentially be used in pain management. Just as a reminder, an opioid, a drug that binds opioid receptors. And when that binding occurs, that action leads to essentially blocking the pain signals from going to the central nervous system, and then obviously that interpretation of your brain saying that hurts. The opioids and meperidine block that pathway. So ultimately, this reduces perception and response to pain. Meperidine dosing, it's in the neighborhood of 50 to 150 milligrams. IM, sub-Q, oral, these are all possible options and can be given IV as well. One additional indication that you may see meperidine used for, it's kind of a unique one, but you may see IV utilized in post-operative shivering. Usually the dosages are going to be maybe a little bit lower than traditional analgesic dosages. 12.5 to 50 milligrams is usually the kind of range there as well. And that may be used in conjunction with dexamethasone. So again, kind of a unique role potentially there for meperidine, may be used in post-operative shivering in some cases. It is important to note that the absorption of this medication can be quite variable, particularly when we're using it IM, sub-Q, or the oral route. So that's important to note that response may be variable, and again, probably one of the many downsides that we have to using this medication. With that said, we've got numerous opioid pain options that are going to be better typically than meperidine. Biggest reason is there's tons of box warnings associated with meperidine. So we've got kind of the standard opioid warnings, addiction, dependence, abuse. We've got risk for respiratory depression, interaction with benzodiazepines, for example, increasing the risk for respiratory depression. So we kind of have those standard opioid box warnings with it. In addition to that, we've got risk for CYP3A4 drug interactions. That is actually a boxed warning with this medication. So that can definitely be problematic in our polypharmacy patients. In addition, MAOIs, it is not recommended, contraindicated to use MAOIs in combination with meperidine as well, and that's an increased risk for respiratory depression. One other note on that CYP3A4 boxed warning, they do specifically mention paying attention to CYP3A4 inducers, and in particular, when we stop CYP3A4 inducers, that can send concentrations of meperidine upward if a patient is on this medication chronically, which, again, it's not something I have seen recently at all, which is great, but just in case we do see this medication, that risk obviously comes, some of the adverse effects risk comes with more frequent use here. So what are those adverse effects? First and foremost, I've got to mention neurotoxicity. I would guess this is most likely to come up on your board exam if you're ever asked about meperidine, or your pharmacology exam, or whatever classes you're taking. So neurotoxicity is the issue with meperidine when it comes to adverse effects, or one of the major issues. And this risk is increased in elderly and patients with renal disease. This medication shows up on the Beers criteria, which is, again, a list of medications that are potentially inappropriate in elderly patients. The neurotoxicity risk increases, obviously, with dose, and it increases with prolonged use as well, in addition to the renal and geriatric issues there. One other important note, this, central nervous system toxicity can lead to seizures. It can lead to delirium, all sorts of negative CNS effects. Naloxone will not reverse this effect. So that is a very, very important thing to remember when we're dealing with meperidine neurotoxicity. Other adverse effects, I think you could probably imagine or guess some of the common generalized opioid adverse effects. Your constipation, your respiratory depression, sedation, skin reactions are possible, itch, rash, things of that nature. Urinary retention has been reported, and of course, abrupt withdrawal. So if you've got a patient who's taking it for a couple weeks or longer, those withdrawal symptoms can start to creep in if we take that medication away too quickly. Again, just a quick reminder on opioid withdrawal symptoms: GI issues, nausea, vomiting, and diarrhea, anxiety, tachycardia, sweating, insomnia, an increase in pain and achiness can happen as well as tremors. So those are a few of the commonly presenting symptoms that you may see associated with opioid withdrawal. All right, let's talk pharmacokinetics here a little bit. So from a metabolic standpoint, meperidine is metabolized to normeperidine. So that is the neurotoxic metabolite that we're really, really worried about. That's done by a bunch of different CYP enzymes, 3A4, 2C19, for example. 2B1 is another one that's listed as well. So again, that metabolite is going to be formed. It's just a matter of if that metabolite is accumulating in, let's say, geriatrics, renal disease type patients, and what extent that metabolite is accumulating as well, and that depends upon dose and length of use and extent of use as well. So definitely some important things to think about there. Tying into the renal issue, if patients have an eGFR of less than 60, it is recommended to avoid use of meperidine. Again, that's due to that increased concentration of normeperidine. Onset of action, IVs in the neighborhood of 5 minutes. Obviously, it makes sense that that's pretty quick. We're getting it right into the circulatory system there. IM, sub-Q, oral probably takes a little bit longer, 10, 15 minutes, depending upon the dosage form that you're using there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like PCPS, ambulatory care, geriatrics, MTM, or the NAPLEX exam, go check out meded101.com/store. We've got a growing list of resources that have helped thousands of pharmacists pass their board exam. So definitely go check that out. Support the sponsor, meded101.com/store. In addition, we've got books on case studies, drug interactions, food medication interactions, pharmacology crossword puzzle books, pharmacy technician books. Definitely go check out all the links at meded101.com/store. Great gift ideas for students, pharmacy technicians, nurses, nurse practitioners, PAs, and so on and so forth. So go check out all those links and find a way to support the sponsor, meded101.com. All right, let's wrap up with drug interactions. So I mentioned CYP3A4 inhibitors in the boxed warnings. So naturally, any CYP3A4 inhibitor is going to increase concentrations of meperidine. Also mentioned in that warning is discontinuing CYP3A4 inducers. That'll also cause those concentrations to go up. Let's talk specifically about inhibitors. Some of the common agents that can inhibit CYP3A4 to varying extents. Verapamil, some of the azole antifungals like ketoconazole, for example. Clarithromycin, grapefruit juice, cimetidine has some action there. Some of the HIV medications that are used as boosters like cobicistat, for example. So there's lots of medications definitely that are CYP3A4 inhibitors that are going to raise concentrations of meperidine and also potentially that toxic metabolite normeperidine as well, which can lead to those CNS changes and seizure risk and delirium and those type of nasty things. Other drug interactions, respiratory depression. We've got to think about meds that can add to that effect. So your benzodiazepines, your gabapentinoids, CNS sedation. We've got anticholinergics, we've got sleepers. All those medications can add on to the adverse effect profile of meperidine. Constipation's another one to think about as well, where drugs like anticholinergics can worsen constipation when used in combination with an opioid like meperidine. And then there is some risk of serotonin syndrome. So drugs with serotonergic activity, SSRIs, for example, they may increase the risk for serotonin syndrome when used in combination with meperidine. Also keep in mind MAOIs, another antidepressant class, are recommended to avoid use with meperidine. And then last but not least, I did want to mention medications that may lower seizure threshold, particularly one that's commonly used, which is bupropion. So that on top of meperidine and, obviously the formation of that normeperidine metabolite, that can increase the potential for a patient to have a seizure. So important drug interaction, I think, to pay attention to there as well. All right, well, I think that's going to wrap up the podcast for today. Hopefully you picked up some practice pearls. If you are looking for a great resource on the top 200 drugs, go check out reallifepharmacology.com. Subscribe there by email. You'll get access to that PDF absolutely for free. If you have any comments, questions, definitely don't hesitate to email me, mededucation101@gmail.com. And of course, if you've benefited from the podcast at all, I would greatly appreciate you supporting the sponsor. Plenty of links there at meded101.com/store. In addition to that, if you'd kindly leave a review on iTunes or whatever platform you're listening to, that would be greatly appreciated as well. Thank you so much for listening. Take care, and I hope you have a great rest of your day.